Now, please. Welcome everyone. Welcome to the meeting of the Board of Directors of Oxleas NHS Trust. Good to see our guests today. We have governors with us and nice to see you. Thanks for coming along today. Apologies for absence. Nina Hingarani Crane has sent her apologies. Sally, are there any other apologies?
No, I don't have any other apologies, Andy.
Okay, thank you. If we go on to the minutes of the last meeting, please. Now, these have been circulated and people have been given the opportunity to add, alter or correct. But for a matter of record, we'll go through and please sing out if you have any matters that haven't already been dealt with. Page 1, page 2, 3, 4, 5, 6, and 7. They're all agreed then. Matters arising, Sally?
Thank you, Andy. The actions taken since the last meeting are laid out in the tracker, which is in the papers. So just to confirm, the capital expenditure paper was circulated and agreed following last month's meeting. The CH report, that's being reviewed again by the patient safety team. And Jane is coming to our June strategy away day to talk more about the new patient safety incident response framework and our process to respond to that. And we discussed the safety governance at the February strategy away day, and work is continuing on that to develop our approach further, including revisiting the committee structure if we need to.
Thank you, Sally. Suzanne, please.
My apologies, Andy. I did send a late correction to Sally Bryden that related to page 4 of the minutes. So I'm sorry to take you back there, but I did ask that under item 9, the record of my comment says that I stated that the RCA approach doesn't require us to find a single cause.
Is that okay, Sally? We got that?
Thanks. Yeah, we can note that and update that, make that amendment. Thank
Okay,
you.
thanks very much. We're now going to go on to the board assurance framework. Ray and Sue, you both raised some very good questions for the board, which we'll answer as we go through, we hope. If we don't answer them, then can you come back to make sure that we have? But I thought it was really helpful, actually, seeing the benefit of new faces already, and it all very, very positive points. So thank you very much for that. On the general issue around the board assurance framework, how long some of them have been on there, and the sort of other questions that Ray and Sue have raised. Stephen Dilworth, did you want to come in at this stage?
Yeah, thanks, Andy, and thanks, Ray. It's a particular question that you raised, which is a very fair challenge in respect of the length that a risk has been on the board assurance framework. So just to give this some context, a risk basically is an event that hasn't yet happened, and will at some stage have an adverse effect on an organisation's objectives. And an issue is something that has happened, and if anything needs immediate action now. So bear that in mind as I just talk through this. So the couple of items that have been on there for about 6 years or so, although the headings have remained the same, the nature of the risk has changed for both of them. And if I take those two examples, one being the vacancies and recruitment pressures, a couple of years ago we would have been talking about the delays in getting references, recruitment for contracts into prisons being the main risks. Whereas now we're looking more at, say, band 5 nurses, the gaps in our staffing levels there. And similarly for the CRE, the efficiencies that we need to achieve, the scale has changed quite significantly. So they're both very different risks to what they would have been originally. But nevertheless, it's a good challenge, because we've only recently, this is the first board meeting, I think, where we've put in that length of time they've been on there. So another option for us to sort of have more clarity on this would in fact be to just create a new risk, perhaps every year on these particular headings, or every couple of years. So that might give a more accurate reflection that although it's under the same heading, the nature of the risk has changed. The other good thing I would say about having the longevity of risk in there is it does, well, apart from the fact it encourages us to reflect as we have now, but also I think it's quite useful for committees themselves and elsewhere in the organisation to think whether a risk should now be tolerated, because if it has been on a register for a particular time. So I think it will have quite a long-term benefit on making people think about should this now be treated as business as usual. But anyway, thanks for the question. I hope that explains sort of the history of those particular risks, why they've been on there a long time. And as I say, the risks have certainly changed, but nevertheless, I take your point, and we might need to think about just changing them on a periodic basis, even though they'd be under the same heading in effect.
Thank you very much, Stephen. And I really like this new format. It gives us a really good overview of the risks. And big thanks to Sue Owen for all the work you've done on presenting it in this way. And obviously, it's provoked quite a lot of interest because we've seen more information about them. Just to reiterate the point, to make sure that we do answer the governor's questions as we go through. And Sally, you'll be our conscience to make sure that if we haven't, we come back and make sure that we have on there. Are there any other questions? Because most of these issues are going to get answered, are they not? I mean, not just the governor's questions, but nearly everything within the board action framework will come up within the presentations. Are there any other questions on the board action framework at the moment before we go to Suzanne, please?
So just a question to you, Andy. Did you want me to talk about the ligature risk management issues here under the BAF, or do you want to wait for the infrastructure committee? Because we did have an extensive discussion about it at infrastructure committee. We could take it there if you like.
Yes, that's a good idea. Should we take it at the infrastructure, please, then, if we may? So thanks very much. We'll move on now to Matthew and the Chief Exec report, please. Thank you.
Thanks, Andy. And just to say, second the sort of praise for the work Sue's done on the board assurance framework. I think it's excellent. It really brings it to life. So the report is there. I assume people have read through it. COVID, Ian will probably mention a bit more in terms of operational pressures, but there's definitely a sense that things are really starting to move in a positive direction now. The vaccination seems to be having impacts on the number of people admitted to hospitals, and there's some very promising results coming through in terms of the protection it offers, both from transmission as well as serious illness. So as a system now, we're very much starting to look at the recovery tasks that we've got ahead and the kinds of services that we really need to focus on over the rest of the year, and also considering things like the impact of the enormous backlogs there are in the physical health system, where we've gone from a situation where, you know, within London, we've moved from having hundreds of people waiting over a year for operations to tens of thousands, and all the consequent impacts of all these, you know, really quite significant physical health care issues, economic challenges, you know, what will happen when furlough eventually ends and so on. So there's a lot of thinking going on. I think it's good that we've got our trust strategy here today, later on in the agenda to consider. And part of that thinking about how we position ourselves strategically, we need to bear in mind the fact that we're just coming out of you know, the biggest healthcare challenge that the country has faced probably in over a century as well. So that gives us a really added context for that. But it's been good to see how our staff has responded to this and how we've managed to roll out the vaccination programme, and we'll hear a bit more on that later on today. One of the things we've done over the last few months as part of our move to build a fairer Oxleas and to create an organisation that is more responsive to what our staff want and what they feel about working for us is to set up a shadow executive. So we've now got, as you can see in the paper, a shadow executive that draws widely from across the organisation. This is a team of people who get access to the full set of executive papers at the same time as the executive team do. and they meet me and other members of the exec to discuss the material that's in the executive papers, and their input is then fed into the decision making within the executive team. And I have to say that their perspectives have been very valuable already. Actually, there's been a number of papers where, because they're approaching it from a different perspective and a fresher perspective from different places within the organisation, they're really helping us change and shape our thinking and open up some of our thinking to a range of different voices. And I'd like the board to hear more from them over the course of this year. There's more in there on building a fairer Oxleas. I think there's some really good work moving forward on that. Anyone who's been watching the Oxwide broadcasts, we've had regular focuses on that, including the work that the Action Plan Group have been helping us with to open ourselves up to understanding the experiences of people from diverse backgrounds within the trust, and to use things like pulse surveys and others to understand the experiences of staff, and to continue the conversation we've had with some of our BAME staff as a result of the initiatives we took following the Black Lives Matter movement last year, but really to emphasise that building a fairer Oxleas is about recognising the diversity amongst all our staff. It isn't just about race, it's not just about gender, it's about the experiences of all of our staff and how they bring that to work, including lived experience in mental health and some of these other areas where we need to do more work and have more of a focus. In terms of recruitment, made a couple of really good appointments recently. Lawrence Mack, who's joined us as Director for Forensics and Prison Services, and he brings to us really considerable experience from across a range of specialist backgrounds within the NHS, including most recently at the Brompton and Harefield. And also Azra, who's been with us for a year in an interim post, but following a full recruitment process, she's been appointed as our Director of Finance after a very strong interview. And people will already know Neil Springham, but he is, of course, with us now as Exec Director of Therapies. So 3 really good appointments there to strengthen our executive team. The big news in the broader system has been the Health and Social Care White Paper, integrating care. And there's a lot in there about promoting greater integration and reducing bureaucracy, taking out some of the unpopular 2012 legislation around competition in the NHS, and creating this kind of duty to work together across ICSs using an ICS board that brings together the local authority sector alongside the NHS. What I would say is there's a long way between a white paper and legislation, and then what falls out the back of that. So I think there's people love to get excited and speculate when white papers come out, and rightly so. But as we saw with the 2012 Act, there was a big difference between what the original policy intentions were and actually what we finally saw in the technical detail that came through the legislation. So I think it's one for us to be very conscious of. I think, though, in terms of the ICS, what we've been doing in South East London and what we as Oxleas have been doing through things like the South London Partnership, through the partnership committee we now have with Lewisham and Greenwich Trust. And earlier this week, we had this sort of inaugural meeting of a VCS, Voluntary and Community Sector Partnership Committee, bringing together Oxleas and some of our partners in the voluntary and community sector. And we're really starting to build this focus on partnership working as a trust, and it's very much been in our blood. So I think a lot of the policy direction in the white paper is not a challenge for us, because that's very much been one of our assets and part of our strategy as a trust longer term. So we're looking forward to strengthening and deepening our partnership relationships with our health and social care partners, and we'll have to see how that policy takes shape once it hits the legislative position. It's worth noting in this context that I'm still trying to digest what was in the budget yesterday, but it does look as though the financial context is going to be very challenging. The COVID impact on the system and the recovery requirements are going to continue well beyond the end of March. And we still need to understand quite how the finances there are going to come through. So Azra will be talking about that later. So the policy direction is positive, but we're in a context where we've just come out of this incredibly challenging pandemic, and it will continue to affect us over the next couple of years. And in that context, money is going to get tighter and tougher as the economic situation in wider society gets harder. So we need to see these positive policy developments in the context of a tough external situation. And as we work our way over the course of today's papers and through the rest of the year, I think this is going to confront us with some pretty interesting and knotty challenges. And there's also another piece of welcome legislative change as well in terms of reform of the Mental Health Act. And the principles around choice and autonomy, least restriction, therapeutic benefit, and the person as an individual. there's some really positive core principles at the heart, but we will need to see the sort of technical context of how this comes through. And what we've seen in the past is that changes around the Mental Health Act, around things like timescales and pathways, they do have operational and clinical implications for us that we need to think about very carefully. So as that works its way through, we need to think about how we as an organisation are ready to meet those challenges. So 2 big ticket pieces of legislative reform that will have implications for Oxleas. And it's worth always, when we're thinking about this, thinking about that external context and looking at things like the financial pressures on many of our partner organisations, not least our local authority partners, and how they affect our ability to deliver in this new world. One thing that's not in my report, but that I will mention, is a big thank you to Lisa, Tan and Sally and the comms team, because we had a really fantastic piece that Sky News did, where they came in and interviewed Drs. Abby Fadipe, Dr. Derek Tracy, Neil Springham, some of our lived experience practitioners and some of our partners in mind, and they ran effectively a sort of 13-minute mini documentary on Oxleas, which has been extremely well received, actually, in terms of bringing attention to the challenges of mental health services during the pandemic. If you haven't watched that, I'd strongly recommend it. It's there's no sensationalism in it. It's a really good piece of work, bringing to life some of the challenges that we faced as a trust, and some of what our patients have faced over the last couple of 12 months or so. And we're hoping to get something else in the pipeline, with thanks to Helen Jones and Sarah Burchell, who've been supporting me with some information about district nursing. So there may be more to come on that stream, but I will update people as and when that's ready. So I think lots going on in terms of the legislative world, and Ian will bring more of the operational challenges to life shortly in his operational report. Very happy to take questions.
Thank you, Matthew. Are there any questions to Matthew? If not, we'll move on to Ian and the operational report, please. Thank you, Ian. Thanks, Matthew.
Thanks very much, Andy. So in your packs, you will have seen that there's the directorate level operational report, plus a slightly revised set of metrics. As per the first wave of the pandemic back in January, we introduced a slightly lighter metrics pack, which we've been reviewing to keep on top of the most essential bits of performance. We will be reviewing that and probably reinstating the full set of metrics from the 1st of April. So what I'll do is I'll just take you through a fairly high level what's been happening since the last board, and draw out some of the detail on a directorate basis, and obviously happy to take questions at the end. So throughout January and February, as Matthew's already said, we saw a resurgence of the pandemic. Everybody will be very aware of that. This certainly had an impact on both staffing but also on our inpatient and prison population. Having said that, although we saw an increase in staffing absence, it wasn't to the same level that we experienced during the first wave. I'm happy to report that that has now receded, and certainly as of this week, we currently have no inpatients with a COVID positive diagnosis, and very small numbers within our prison population, which continues to reduce. And our COVID-related staff absence has also decreased throughout this time, although we have experienced a slightly higher percentage of clinically extremely vulnerable staff in the last couple of weeks, and that's because the national guidance has changed as to who is included in that group. So we're just doing a piece of work, or I'm doing a piece of work with the service directors, just to understand whether that is going to cause any significant operational pressures if staff in that category can't come into work. In terms of staff vaccinations, Matthew again has already alluded to this, but the first round of staff vaccinations has now finished, and we have been vaccinating selected cohorts of inpatient groups, and Jane and colleagues are preparing for the second round of staff vaccinations, which will be starting soon and will be carried out down at Queen Mary's Hospital. So that's COVID. In terms of performance, I think I reported this at the last board. We instituted our business continuity plans for our adult community physical health services back at the beginning of January, and this was to support flow from our local acute providers. In prison services, the national direction was given to healthcare providers very much in line with the first wave. So there has been a kind of reduction in the and a prioritisation of services to prisoners. However, all other service lines within the trust have continued as normal. We've experienced increased pressure across a number of our community physical health teams during the second wave of the pandemic, and this has steadily increased. Particularly, it's been felt by our district nurses, our cardiac team, diabetes and respiratory teams. Mitigations have been implemented, and I've certainly talked through some of that in our Performance Quality Assurance Committee. However, it is something that we are keeping a close eye on as the pressure is likely to continue, particularly as our acute provider colleagues bring back more of their elective capacity. And some of that pressure we've been experiencing in the community has been by design, and it's been part of, for instance, developing the virtual wards model in the community. In terms of adult mental health, demand for beds has picked up and has pretty much returned to normal levels of demand in February. Despite that, we had by the end of February reduced our UEA usage. What I mean by that is our private bed usage outside of our contract with the Priory to zero. And we've managed to maintain that into the beginning of March. But the pressure is certainly there. So we are continuing to focus on delays and flow within our inpatient wards to try and maximise the capacity whilst we restart the work, which fits under the two strategic priorities of great out of hospital care and zero delays. And this will certainly encompass the work that we need to do within our community mental health teams in terms of transformation to support that sustained reduction in demand for beds that we need. I just wanted to highlight, because it mentions it in the report, something around our children and young people services. I just wanted to highlight that after considerable work by the Directorate, helped by colleagues in Alice's team, and the Directorate have arrived at a position where they have a much clearer sense on their weights within CAMS and are working hard on how to reduce delay. At the moment, there's work going on to understand where there are capacity issues and work being done on productivity. Having said that, it's important for colleagues at the board to understand that delays have increased during the pandemic, and this is partly due to an increase in crisis presentations, which draw staff away from routine work and inevitably has an impact on people who are waiting for routine appointments. But I think there's a confidence within the Directorate that we, although it's going to be a challenge to meet demands, that we're in a much better place in understanding what is happening. And the other thing I just wanted to mention in relation to children and young people services, that our health visiting service in Greenwich will be transferring out of the trust at the end of March. I just wanted to thank Lisa, the Director, and her team for their leadership and support to staff and to the staff themselves, who continue to deliver an excellent service and have demonstrated real professionalism. I think through a difficult period, which has been a lot longer than we anticipated, partly because of COVID. So I'm going to stop there. There is obviously further detail in the pack on the individual directorates, and very happy to try and answer questions. Thank you.
Yeah, thank you, Ian. Joe Stimpson, please.
Thanks, Andy. Thanks, Ian. I just wanted to reflect a bit further on your report, and as you mentioned, there is a strong theme of increased demand across, the whole breadth of services, and clearly, we've got localised initiatives in place to deal with that. There may be some efficiencies that we can gain. I guess as we move into this year, it would be good to get a sense of how much we think some of that is responding to a peak, probably or maybe caused by COVID, and we think things are going to return to more historically normal levels, and how much is structural. I mean, I was particularly taken by that increase in on the diabetes team, for example. I know that may be, partly part of the sort of home first approach, but I think as we go forward, we need to understand, how much is peak response that we're dealing with, and how much is there's been a shift, and these people are going to be with us for a long time, and how we approach that.
Yeah, thanks, Jo. I mean, I think it's probably a mixture of both on the physical health side. So, in a sense, the Home First initiative was something that we, as a system, I think have wanted to put in place prior to the pandemic. However, I think the pandemic has probably accelerated the pace of that change, plus driven a slightly a change in the demand both for acute and community services. So some of that increase was anticipated and is by design. Some of it is simply a result of kind of changes to the patient population. A good example of that would be the respiratory stuff that we're doing. I think it will be a challenge to make sure that we have the resources to meet that demand, and I think that is related to the Home First business case. I think within that there's a desire to look at rebalancing how much activity is in the community as opposed to bedded services. But that's not a conversation that is just limited to Oxleas. It obviously encompasses the activities going through the acute providers as well. So I think that will be a slightly more difficult conversation. But having said that, I think relationships locally are really good, and we're in a good place as a system to try, well, certainly to kind of share those pressures, but also to think how we design the kind of solution together. So. Yeah, I feel confident that we've got the structure to kind of try and resolve it. The issue will be whether the resources are
there. Stephen Dilworth, please.
Thanks, Andy, and thanks, Ian, for the very comprehensive report. First of all, an observation. Good to see that work on the mental health assessment unit at the PRU, because I think that will add a lot of value to what we deliver on that site. Two questions. Like Joe, noticed the 73% increase in the caseload on diabetes. I'm just curious to know whether virtual appointments, there's some flexibility on virtual appointments with that service. Is that happening? Are we making use of that? Is that some way of coping with a greater workload? And then the other thing is just on page 41 of the bundle where you talk about the 72-hour breaches. Is that down to the kind of staffing COVID-related issues that you referred to? And is that a sort of one-off for the month? And are we expecting it to come back to normal sort of during the February-March figures? Thank you.
Yeah, so in answer to the first point, I think there is a virtual offer within the diabetic service, and I think our community health services have been pretty agile in embracing that. I think the other way through it is to continue to look at opportunities for providing some of these smaller smaller services at scale across both Greenwich and Bexley. And again, that's something that we're exploring. So I think there are a number of things that we're looking at around that. In terms of the 72-hour breaches, it's something that we've been monitoring through Performance Quality Assurance Committee. there was a kind of drop in performance towards the end of last year, and then it picked up again across all boroughs. However, I think we there has clearly been a blip this month in January, but I am confident that will improve in months to come. But it's something that we need to focus on. It should be something that's in the kind of recedes into the wallpaper. This is a really, really important metric with a good evidence base behind it. So it's really, really important that we are focused in on it.
Thank you, Ian. Suzanne, please.
Thank you, Chair. I just wanted to reflect in on the language of admission diversion, which you use in your report, and then the term admission avoidance comes up later on in some of the papers. And I'm a little bit concerned that if we focus on the goal of admission diversion or avoidance, that becomes what we aim for, rather than ensuring that we're providing an appropriate service for people when they need inpatient or outpatient provision. And I'm just wondering whether we can't find a more appropriate way of encapsulating in a phrase what our goal is here, so that we don't unwittingly give the message to our staff that our main goal is to avoid admission.
Yeah, I think it's a very fair point, Suzanne, and I think language is important, not just for our staff, but also for the public and our patients. And I think particularly words like avoidance are quite loaded. I think what we're trying to achieve is the right treatment in the right place for the right people. And I think there is a fairly good evidence base that there are some groups of patients or some diagnoses that don't necessarily respond well to an inpatient admission. And that's not to suggest for a minute that those people don't need treatment or that they don't often present risks, but often the kind of just simply bringing people into an inpatient setting isn't enough in itself, and it's more about the kind of active treatment that they get and having a more thoughtful, joined up approach with them around where they receive their care. So I agree that I think it can be, it can be used in quite a concrete way, and we just need to be careful about that. So I think it's more about purposeful admission. That's what we're trying to arrive at, and being clear about the need for somebody to be in an inpatient unit. Has that been discussed with them? Has it been discussed with their families? And then a decision collectively arrived at as to whether that is the case, or whether actually this could be done. The treatment could be carried out in the community. So I will certainly kind of take that away, Suzanne, and think about how we kind of weave that into our approach.
Thank you.
Thank you, Ian. Is that Azra? Your hand up? Was that Azra?
I think
No, I
Yemisi.
don't think it's me.
Yemisi's got a hand up, I think, Andy.
Okay. Sorry, Azra, did you have your hand up?
No.
No. Okay, thank you. Yemisi then, please.
Thanks, Andy. Ian, it was just a quick question on page 70. It's about the annual leave carryover for staff. I know the criteria is only to those who cancelled their leave due to COVID-related pressures, but how many, the numbers are we talking about? Because I can imagine many of our staff this applies to. And I think I was just thinking whether that would have an impact on maybe agency use next year if our staff capacity goes down because of it. I didn't know how significant that was.
Rachel may want to come in on this point. I think we've kind of left it to the service directorates to kind of work this out for their own services. I think it's been quite limited. The way that we've established the criteria, it's limited the pool of people who fit into that first category in terms of the carry forward of 4 weeks, because obviously, as you say, that would have a significant issue for next year. So we've really tried to kind of limit the kind of criteria around that group. I don't know if Rachel, if you wanted to say any more about that.
So sorry, Emma, my connection is poor. Would you mind repeating the question?
Yes, Rachel. In terms of the annual leave, I was wondering how many people that affected, because the way I've read it, it says it would be those who would help him with COVID-related pressures, which could affect quite a large cohort of our staff, and whether that then has implications to, say, agency rate figures for next year, or pressures on staff capacity because of that.
Thanks, Emma. So when it comes to annual leave, there are 2 different categories. So there are the people who we specifically asked to cancel their leave or change their leave because of COVID pressures. We've tried, as you might expect, to avoid that wherever possible. So that's a fairly narrow group of people, and that's been subject to guidance centrally from the NHS, which has said that those people have 2 years to carry that over. So that enables us to do that in a way which smooths it over quite a long period. So my hope is we wouldn't see a peak at any one time, but it enables those people who very kindly cancel their arrangements to be able to make sure that they don't lose out. There's a wider category of people who we know who've struggled to take their leaves this year for a variety of reasons, mainly because they've been, really making sure that they keep the show on the road. We've changed our annual leave approach for that group, which applies to everybody actually, meaning that rather than having 2 days that you can carry over, you can have 5 days carry over. And we're also buying back up to 5 days leave from people who haven't been able to use it. So our hope is that that gives people the right, that we prioritise making sure that people are able to have a break, because I think that's really important after everything that everybody's been through. We enable it to kind of smooth out over a period, so we don't have any particular peaks at any one particular time. But also, it means that we can start moving forward and people are able to buy back up to 5 days leave. So we've tried to strike the right balance in terms of making sure that we don't have peaks, but we also focus on well-being.
Thank you, Rachel. Steve James, please.
Thanks, Andy. It's a very comprehensive report, so it's very easy to get to grips with some of the issues. I suppose the issue that bothers me, which has bothered me for a while really, is the effect on community teams, both physical health teams, so the district nursing teams, and also the community-based mental health teams, because it seems to me we are doing quite a lot of work in relation to the system and the beds and what support people need in the community. But there are some hot spots now which worry me on our way through. So I was in the ED department at QE last week, and people who were in the unit were having to wait significantly long times for assessments. And that's, I was told, because of the pressure on the teams. And I don't know whether or not in the middle of us trying to reorganise the different concentrations of service between community and beds, we might want to spend a bit of effort on addressing a couple of hot spots, because, first of all, because of the effect on patients. So it's not a good thing to be sitting in that unit in Queen Elizabeth's for, over a day. But the other thing is what our regulators will think of this should they turn up. And we have in the past had some difficulties. I think that they were right sometimes. Are we going to address some specific hot spots in the middle of the bigger piece of work about rebalancing the services?
Ian,
we have some issues now, I think, so what we're going to do this week, next week.
Ian, before you come in, thanks, Steve. I was going to ask you to expand on that point, Ian, on the conversation that we had yesterday about similar issues about delays and whether or not this is a particular spike at the moment or whether this is an endemic problem. And then how do we deal with people who are waiting at ED, waiting for a bed, waiting in the 136 suite or whatever. And I suppose what was crossing my mind is, I mean, Steve talked about it just then. What would our regulator think about the situation at the moment? We've tried it, we know in the past, we've tried sitting on sofas, we've tried a whole range of things. This is a long-term issue, but I think answering Steve's point about what are the problems we've got now, please.
Yeah, so the first thing I think is to just to kind of clarify why people may wait a long time in the department. I'd be very surprised, Steve, if it was waiting for assessment, given that our average time for responding to referrals is about 90 minutes. Where people wait longer for assessment, and there was a case last week, is because sometimes it takes a long time for them to be medically cleared. So I'll give you an example of somebody last week who waited around about 20 hours before we could assess them. And that's because they'd taken a fairly significant heroin overdose and they needed to be medically treated before we could see them and make a decision around what we were going to do, which in the end was to admit. So typically the reason why people wait for a long time or can wait for a long time is around well, for a number of reasons. Sometimes it's about bed availability. Sometimes, and we have done a recent analysis over a few weeks of activity, sometimes it's because the person doesn't want to go to the bed that we've offered them. Sometimes it's because the relatives don't agree with the treatment plan and are quite insistent that they need to come in hospital. So there's a number of different scenarios that get played out. Obviously, the assessment suite that we've created at QE is a much better place to for somebody to wait. Doesn't excuse the fact that people shouldn't be waiting a long time. In terms of how many people are waiting a long time for admission, the thing that we measure obviously is the significant thing that we look for is the 12-hour breach. We try and get everybody out within 12 hours or less. At the moment, we are kind of averaging in the last couple of weeks as pressure has built up. It's probably averaged about one a day, although there are days when we don't have any breaches at all. But there is something about pressure is increasing. So yesterday we had something like 15 presentations for admission across our two EDs, which is about 4 times what we would normally experience. So there's no doubt that there is some pressure there and that we need to work through. So the question, we need to get underneath it, whether if people are being delayed for in terms of their admission, can we do more to kind of create more capacity? We know from data that we now collect regularly that we have real differences between our wards in terms of length of stay. And that's why, as it says in the report, we're trying to focus in on that at the moment, because even some shift in the length of stay that we experience or the variation would create more capacity and would enable us to bring people in and would therefore reduce the amount of time that people are waiting. And that with the kind of safety valve that we've built in with the prior rating, we can get out of this, but the issue is we often have surges, and yesterday was an example, and these surges come out of nowhere, and it's about having sufficient headroom to kind of manage that. So I'm not sure if I've answered the question, apart from the fact that we are very excited on it. I am very excited on it because I personally get involved in a number of these breaches every day, and that is something that that shouldn't need that level of input. So it's about how do we kind of create a much more systemic response to that. I don't know if Matthew, if you want to say anything more on that.
Just to say one or two things, there's a few bits and pieces around how and where we put investment to try to address some of these pressures. So, for example, the mental health assessment units, what they're doing is they are offering more space within the emergency department environment or co-located with that to care for people who are waiting for admission or who were putting in plans for discharge, and it takes them out of majors. So the situation where we're in, where we've had, say yesterday, where we had I think 4 or 5 people waiting at QE for an admission or for their onward plan, you know, before the mental health assessment suite opened, that would have meant 25% of the QE cubicles in majors would have been full of mental health patients while they were waiting for the bed. Because we've opened that assessment unit, they weren't waiting in majors. They were waiting in a much calmer, more appropriate area, staffed by mental health staff. Likewise, at the PRU, we'll soon have, I think, a 5 patient unit away from the ED where people can wait. The combined cost to Oxleas of running these 2 units is going to be around £1.6 million. Now, around 50% of the patients who come through these units, we think from our initial analysis, Simon's doing more work on this, are people who don't end up being admitted and in fact don't end up under secondary mental health care services. So what we're doing there is we're going to, you know, looking at next business year, we're potentially going to be spending around £800,000 on people who don't fall under the Oxleas ongoing treatment remit. You know, we're also spending £80,000 supporting London Ambulance Service with their mental health joint response car, where 96% of those patients don't end up under secondary mental health care. So there's a significant investment there from Oxleas on services which I think are the right thing to do, because it's avoiding some real hot spots around people who present a mental health crisis. But we are spending mental health care money on services where actually they're not primary mental health care patients. And if you think about the money we've saved by closing some of those beds, quite a lot of that is now being eaten up by putting in these things, which are the right thing to do, as I said, but are expensive. And when you think about where we balance things off, do you invest the money, the increasingly small pool of money, in inpatient beds? Do you invest them in ED alternatives? Do you invest them in community teams? Do you invest them in IAP further downstream, etc.? There's a constant balancing act to try to avoid where the sharp spots are. The only way to avoid the kind of surge we saw yesterday is to get the bed base down to running at 85% occupancy, because that would give you the headroom to deal with 4 days activity in 1 day potentially. But the challenge around that is that, you know, to get to 85% occupancy, you either open a lot more beds where there isn't a workforce there to do it at the minute without pouring millions of pounds into agency and bank staff, or you invest in community and be prepared for the slower burn. So this is a constant set of operational priorities that we're trying to challenge, to juggle as an executive, and that we're trying to work through with the system as well, you know. So there aren't simple answers to this, but there's a range of interventions. And I think what we can see in the performance report is the really quite significant inroads we've made to the admissions over the last year. You know, we have brought that flow down, and we have got some really positive investments happening in the community. But you know, this is a tough set of circumstances, and without a lot of redundant bed capacity sat there, or you know, the NHS talks about as redundant capacity. Really, it's what the Royal Colleges would recommend. You know, that is not an affordable context for us, really. So, well, I mean, we might talk about this more in the finances later. And I know Azra and team, we are preparing for some discussions with the ICS about funding of things like these mental health assessment units, because, you know, we could close both of them and open another ward. I think it would set our relationships with QE back years if we did that kind of thing, you know. So some of this is about thinking about system working as well as where we're addressing these most pressing pressures. So you know, the context is always really important when we're thinking about this. But thanks to Ian and the team for, you know, it's still worth reflecting on the fact that we've got 2 wards closed compared to where we were this time last year, and we're still by and large managing these pressures in a better way than we were, albeit we'll still hit the buffers when we get 4 days activity in a 24-hour period.
Yeah, thanks, Matthew. Suzanne, please.
I'm slightly changing the subject here. I just wanted to take the opportunity to note a couple of things within Ian's report that I was really pleased to see. And one was the service development plan for the CMHT in Greenwich. I thought it was really helpful to see those very clear goals set out, and to have a sense of how this CMHT is going to build its resilience. So I'd just like to acknowledge that. The other thing is that we've talked a lot about the pressure on our community-based physical health services. And that pressure is obviously a worry, but I think we also owe a huge debt of gratitude to the staff who are carrying that additional load. You know, to see the kind of rise in the number of referrals and the additional scope of work that they're having to get on top of. You know, congratulations to those teams who are managing to keep on top of it in a very difficult situation.
Thank you, Suzanne. Are there any other questions for Ian at all from his report? If not, thank you very much, and thank you to you and all of the team really for dealing with this huge demand and pressure that you've got at the moment. And I know just how much you personally put into this to try and deal with so many of these issues in real time as well. So thank you for that. We'll move on now to the Oxleas strategy. Matthew and Rachel, please.
I think I'll kick off, Andy, if that's all right. Hello, everyone. So you have in your papers our proposed strategy for the next 3 years. Drafting this has been a real team effort, actually, with brilliant input from all of our non-executive directors, our executive directors and all of their teams. And on a personal level, I've really enjoyed working with everybody to get this to the place that it's in at the moment. It's worth remembering that the strategy and the agreed priorities within it and the building blocks all have their foundations in the large-scale engagement exercise that was in full throttle this time last year, the work to establish our next step, and that was sadly blighted by the pandemic. The closer to home events, the team sessions, the surveys, the workshops, all contributed to us having a much deeper understanding about what matters to our patients, to our communities and to our staff. And I think it was the right decision to pause before wrapping up that work to consider the considerable impact of the pandemic and what it would mean for us and our future. So much is different in our new world, not least our understanding of health inequalities, of our ability to respond at pace to new challenges, of our ability to use digital to deliver services, our finances, and so much more, all elements that fundamentally change our context and our future. So my hope is that this new strategy does justice to all that we learned through the Our Next Step work, through the Building a Fairer Oxleas work and through the pandemic. I promised a document of no longer than 20 pages and I've just about managed that, but we'll soon be adding in service user stories and quality improvement work and all of that, so it probably will be slightly longer than that. There are a few small minor additions I'd like to make. People have, since the paper's been put in the board pack, people have kept coming with their ideas and I've really wanted to embrace that. So there are a few additional sentences around health inequalities, a little bit more about the importance of aligning mental and physical health for our patients, a bit more about our leadership and development programme, a little bit more about prisons, and a request that we change the reference to mission to purpose. So all of that will be in the final document. All of these have been sent to the board previously, so I'm hoping that everyone's happy with it and don't change the overall thrust of the document. Very briefly about next steps, it falls into 3 broad categories. First, we'll be wanting to work together to supplement this document with a measurement strategy and an action plan that has clear accountabilities for particular individuals. Personally, I want this to be as simple as we can make it so that we can really easily track progress. And the plan is for us to consider it on a regular basis, both at the executive and also every 4 months at the board. Secondly, I want us to embed the strategy in all our work areas, from our individual objectives to the materials that we use, and also to make sure that we review all of our existing strategies so that they align with this direction of travel. And we're going to be sharing it with our key stakeholders again too. Finally, and perhaps most importantly, we want to create a simplified version of the document, ideally with a simple 1-page visual that makes it really easy for our staff to remember. We want to supplement it with animation, and we want to create programmes of activities for staff to roll up their sleeves and really deliver these changes that we're hoping to deliver. That's what I was going to say, Chair. I hope you all feel that this is the right direction of travel for Oxleas, and I'm very happy to take questions.
Thank you, Rachel. Thanks for the huge amount of work that's gone into this. Any questions for Rachel, please? I can't see any. So, Suzanne. Yes, thank you, Suzanne.
Sorry, it's getting to that button quickly enough. I'm sorry, this is a really boring process question, Rachel. It was about the process of developing the indicators, the measures, the KPIs, which I think are going to be absolutely critical to this. Is there going to be a process of engaging NEDs in the development of those indicators? And how far are you anticipating that they will kind of impact on our thinking about, in particular, about outcomes?
Thanks, Suzanne. So this has been a really collaborative process to date, and I want it to be a really collaborative process going forward. So we're going to have a discussion at the exec about how we start to flesh out the ideas about measurement that are already in the document, but also hoping to use time at the next strategy session with the board to start that conversation too. But then it will come back to the May board for sign off. So hopefully it will be fully visible and everyone will have a chance to contribute.
Thank you. Jo, please, Jo Stimpson.
Thanks. Just 2 points from me. I made the point to Rachel as part of the consultation that I thought we could have a bit more about prisons in there, and I think you've put a bit more about prisons, but I wondered if there were, I don't think we need a lot, but I'd like prison staff and prison stakeholders to recognise themselves in the document, and I think there may be opportunities in terms of, you know, the main strategic priorities, just to sort of mention a couple of sentences how that might apply to the prison environment. So, you know, great out of hospital care in a prison presumably means in reach into cells, for example. So it might be just quite good so that then we've got some things that people recognise. And the other thing, and I did make this point just on page 86 of the bundle, this is about the safety culture. We've got a number of bullet points for mental health services and physical health services, safety priorities. For learning disability services, we say learning from death, including leader. That may well just be a placeholder, but we should have a few of the bullets from leader, I think, in there, because they should be our safety priorities. It just feels odd to me that you just have learning from death. It's like we wait for someone to die and then we learn from it. It doesn't feel right. We know what the priorities are. We just otherwise, I think a huge amount of work, but I think it's really.
Yeah, thank you, Jo. Matthew,
Happy to take those on board, Andy.
Sorry?
Happy to take those on board. Thank you.
Okay, thank you. Matthew, please.
Andy, I know there was a question from the governors about the recurrent SIPs. I don't know if you want Azra to talk about that now or to pick that up in the finance update later.
If you could pick that one, the finance, that might be helpful. Thank you. Steve James.
Thank you. I think this is a very good document. I think it's very clear as it demonstrates the way the priorities for the trust and how we're going to deliver some of them. I suppose my only comment was not to underestimate the change that's contained in this document. I mean, I think that nothing about us without us is clearly right, but there are some bits of the trust that have a bit of a journey to go on to get to that point, I think. So I think we shouldn't I don't think this is just a bit of a change of more of the same. I think there are some fundamental changes in there. I completely agree with them, but I wouldn't want to underestimate the effort that we will have to go through in order to deliver it. It's a bit like also having a more centrally defined set of things about quality. I think the quality committee for years discussed whether or not we could have 2 or 3 different ways of measuring the same thing, and I think got to the point where we couldn't as a trust. There needed to be an Oxleas definition of a number of things. I again think that some bits of the trust have a bit of a way to go for that, because you have to balance the sort of clinical decision making. But overall, I really welcome the document. I echo, the only other thing was what Jo said about the prisons. I think that, you know, given that they are a priority for us, given that they're a potential area for us to grow, people in that world need to recognise themselves if they read this document.
Good point, Steve. Thanks very much indeed. Any more from anyone else? Rachel, again, I'd add the thanks to you and everyone else who's contributed to this. There's been a huge amount of work going into it, and to bring it down to this level actually is really, really well done. I think you're coming to us to agree this, are you not?
That's right. Yes, Andy.
Yes. So for the members of the board, do we agree? Do we approve this strategy? That seems to be unanimous. Thank you very much. Well done, Rachel. Thank you so much to you and everyone else has contributed to this. Now we continue now, Rachel. I think this is with you again. Freedom to speak up, self-review.
Thanks. Yes, Andy. I can be a bit more brief on this one, I think. So as you know, we're expected to conduct a board self-review of our Freedom to Speak Up approach every 2 years. Our last review was in 2019. The board heard from the Independent Guardian Service at the last meeting. I think had a really good discussion. And I think what came clearly through from that was that the arrangements are working well in Oxleas at the moment. We do have ambitious plans for further raising the profile of the Guardian Service, and this is already progressing well, and a lot is happening even in the last week. The document captures the considerable amount of work that's gone on over the last few years to really deliver on our ambitions to create a culture where staff feel able and supported to speak up. And it contains input from executives and non-executives, as well as from the Guardian Service, and I commend it to the board for adoption.
Any questions, colleagues? In the absence of any questions, we are asked to approve. Do we approve? That appears to be unanimous. Well done. Thank you very much indeed, Rachel. I'm very grateful. We'll move on to the mortality surveillance report, and I think that's Jane, please.
Thank you. We saw 287 deaths in Q2, which was very similar to a usual Q2 period, as compared to Q1, where we saw a very dramatic increase in deaths. We haven't actually seen the same dramatic increase in Q3, although there is a rise against what we would have expected last year. If we look at the graphs, the deaths always appear highest in Bexley, and I understand there's been a query about this. But to explain it, we provide community health services in Bexley and Greenwich. Predominantly, this is district nursing, which provides a high level of end-of-life care. So if we were to compare Bexley with Bromley, for example, we would see the demographics of Bromley and Bexley would have very high levels of older people dying, which is what is reflected in these reports. Greenwich has a slightly different demographic, a slightly more varied population and a younger demographic profile. So that explains why we have more deaths in Bexley and we provide significantly more end-of-life care. During Q2, we took the opportunity to try to reflect on some of the local and national learning that was coming out of the reflections about the first wave of the pandemic. And we particularly revisited the learning disability report, the national report. And in light of the comments that we've just had around the strategy, I think that this leader report really clearly identifies the core areas that we will need to be looking at. And what the ALD services have been focusing on, for example, is raising awareness of mental capacity. They've been embedding an epilepsy pathway, and they've been developing a resource for physical health deterioration in care homes. And another question has come up is how the teams are supporting people to access screening for cancer particularly. And we've got a long track record of working with primary care and facilitating health checks and actually going with people to appointments where required and providing easy read material so that they can be informed and supported to access checks, which would be screening for cancer, for example. We also looked internally about whether there was any learning that we could take from Holbrook Ward, which early in the pandemic experienced our highest number of deaths. We were particularly interested in how the ward had managed to adjust to the rapidly changing guidance and new ways of working. And we found that our review of all of the deaths had shown that the guidance had been followed, that there had been good communication with all of the team working there. And actually the team had been incredibly compassionate and sensitive at what must have been one of the hardest things that they've had to endure in their working lives. And then two other national reports that we looked at. One was the sudden unexpected deaths in infancy, which showed that there was a disproportionate occurrence in families, not due to maltreatment or mistreatment, but where there were other vulnerabilities present. And we held a Think Family safeguarding event last week, which was attended by around 100 of our staff across the organisation. And this was a major feature in the presentations, and there was a lot of learning that came out of that. And then finally, we looked at a very small national report that came out on the child mortality database, which was looking at suicide in young people. And the numbers are very small. It's very difficult. The report says its limitations are that it isn't really significant statistically, but there was some really good information about the emerging risk factors, which we needed to be cognizant of in terms of our children and young people, and making sure that where we're working with adults that we're really mindful of children that might be in the household or the wider network. And the report particularly highlighted areas of education, isolation, tension at home and disruption of services as factors to note. And particularly the CAM service have been working very hard to make sure that they're supporting families. The issue of isolation was well highlighted here. So that's the key learning that we wanted to include in our Q2 report. I'll pause there to see if there's any questions.
Any questions for Jane at all? We have one hand up there. Steve James, please, and then Suzanne.
It's just a question around people with learning disabilities. Was there any increase in that quarter over and above what you would expect of deaths of people with learning disabilities? I asked that because there was not a spike, but a significant increase in Lewisham and Greenwich Trust reported deaths.
If memory serves me right, I think there was a spike. I can go back and check the actual numbers for you, Steve, but we did see a rise in deaths in people with learning disabilities during the period of the early pandemic.
It would be useful to know how they died, what they died of.
Okay, some of them did die of COVID. We do know that.
Thanks.
I'll get that for you.
Suzanne?
I was going to defer to Amlan here, actually, Andy, because I think his hand went up before mine did. You spotted mine more quickly.
Okay, Amlan, please.
That's very kind, Suzanne. I think it was maybe a millisecond or two. Jane, thank you very much for this report. I really value the detail in here. I think it's really, really helpful. One of the things I just wanted to pick up on was how we, I guess, loop round the lessons to assure ourselves that those lessons are being embedded. So things like, dysphagia training or capacity assessments, etc. Do we have routine rhythms under this kind of bracket? We would follow those things up.
These are generally picked up through the patient safety route or through the clinical effectiveness route, depending on what they are. But what we're trying to do is reflect on the common themes that have been coming out of our incidents so that we can do more focused work around quality improvement, particularly on things like mental capacity, which comes up often.
Right, thank you. So I think what you're saying is that for each of these lessons, there is an existing embedded pathway of assurance that makes sure when none of these lessons get kind of missed.
Yes, that's both through the directorate and through the trust as well.
Lovely. Thank you, Jane.
Thank you. Suzanne, please.
Thank you. I had one question and one suggestion. The question, I'm sorry about this, Jane, but I think when we had a discussion about the paper that came to PQAC, there was a section in there which includes the sort of avoidability assessment per the RCP methodology. And that section seems to be missing from this version. I don't know whether that was deliberate. My comment was actually about the leader reviews and kind of other of these national papers. I wonder if it might be useful to have a gap analysis so that one could kind of see at a glance in future when the national report comes forward, you know, that this is what it said, this is where we stand on it, and this is where there's any kind of, you know, this is where there is a gap if there is one.
That's a really helpful suggestion. We can certainly do that when we look at future learning, and we've certainly done it before for some of the previous learning. In terms of the structured judgment reviews, we did remove that table following PQAC and discussions with yourself, because we didn't feel it was adding any value and it was causing some confusion. So we'll continue to monitor the Royal College of Psychiatrists quality reviews within the Mortality Committee, but we won't report on it unless there's anything exceptional to report following the feedback.
Thank you. Jo Stimpson, please.
Thanks. I just wanted to add a couple of comments. So on the learning disability, the lessons from the leader reports, you know, there is always stuff for us to pick up, and I think in terms of that directorate, they are pretty good at picking things up. Elaine is very thorough. I think where there is more opportunity or further opportunity, and is how we take this out into the wider system, because a lot of these issues are not first handled by us, they're handled by primary care or by acute providers. And I still think we have an opportunity to take even more of a leadership role locally on some of these issues. Because I have to say, when we, and I sit on the committee, when we look at some of these deaths, the years of premature death is really quite shocking, and it's pretty pervasive. You know, the fact that no one should die of constipation and yet people do. You know, there is good news in here that learning disability is being put down less as a cause of death, but on occasions it's still being put down. So I do think you know, there is perhaps at an ICS level more we can push on with here. The other point I wanted to make was just on child deaths. So for clearly at the end of the month we won't have any health visiting services, so we won't see many young baby deaths coming through, because it's our health visiting services that will pick these up. But just to emphasise the point about where we're seeing child deaths in families with other vulnerabilities, we continue to see this. We don't see too many sudden child deaths, but when we do, we can often identify issues of sleeping and things like that. And it would be good to ensure, I'm not quite sure how we can do it, that when the new service starts, that they are maintaining some of the messages that we push with on that.
Thank you, Jo. Anyone else? Any questions at all for Jane? If not, I think we're asked to note this report, Jane. So noted, and thanks very much indeed for all the work you do on this. Thank you, and thank you, Jo, as well. We'll move on now to the charity accounts. Azra, please. Thank you.
Thank you. So I'm going to take the full report as read, but just draw out some key themes. So as of last year, we had spent there was a movement of 114,000 on the charitable funds due to the fact that we actually spent 155,000 in year. That then left us with a balance of 463,000 of funds entering the year, of which 232,000 were restricted, i.e. they had a specific purpose that they had to meet, and that alters what we can affect. Well, it basically restricts what we can spend that money on. These accounts were consolidated into the overall trust accounts for 2019-20, and the feedback from the auditors at that time is that they were immaterial in regards to creating the group accounts. And that's one of the reasons, picking up one of the governor's points, that we didn't fill in all of the bottom element in regards to quality, workforce, sustainability and partnerships, because the materiality of these figures on really impacting on those areas was considered immaterial. But I think in future we will try to just draw out some of the key themes of those. For example, we've got the staff assemblies funds within there, which would obviously have an impact on workforce, and we've got some elements that we're spending both on service users and patients, as well as within our own staff and our facilities. The accounts have been reviewed and have gone through the Audit and Risk Committee. And picking up the point in regards again to a governor question around the delays, there is no impact in regards to the delay in sending the accounts through to the Charities Commission. It's been completely driven by the fact that our auditors were not able to give their independent review, and there was a recognition by the Charities Commission across the board that there would be some delays on getting some of those approvals and audit requirements through, given COVID for this year. There was another question that was raised by the governors that I'll just pick up while I'm doing the summary, and that was around on page 12 of the actual accounts. There was an issue, and I think it meant, why was the £4,800 of admin and management costs not waived rather than waived? Because we have actually accounted for those costs within the charitable funds, and that is a very small proportion that we appoint in regards to all of the resources that we put in to actually administer those funds. I have to say, it's not a complete 100% cost recharge. It's been kept at quite a minimal rate, principally because we didn't want to burn through all of the charitable funds as we were going through year on year, because that would then reduce the amount that we had available. But it is important that we factor in all of the costs that are associated with actually running, well, it's not all of them, a minimal cost in terms of running. And then the final question that had come through was around further promoting the charitable funds. Now, historically, we've not done that apparently within the trust, but I'd be interested if there was any board drive towards getting that done, because I think there are a couple of ways that we could approach and develop that in future years. And I'd be happy to take that on board and come up with a set of recommendations and suggestions that we could then take through the executive and then through the audit committee or the business committee, depending on whereabouts the board would like that managed. That's all I was going to say on that, but happy to take any additional questions.
Thanks very much, Ezra. I think, one of the issues in the past, before your arrival, was the fact we didn't spend it. It sat there, and I'm pleased to say we are spending, but clearly there's more we could spend. I think we'd always like some money to come in, as long as we knew we had what we're going to do with it, and what can we do for our staff, for our patients, through charitable funds. So it's good to see some more energy behind this, but this money shouldn't sit around, should it? It should be used. And if it's used for a good purpose, then we should try and replenish that from whatever source we can. Are there any questions from other colleagues, please? In the absence of those, from Joe, from your perspective on the money front, are you happy with everything?
Yeah, absolutely. And this has been through both business committee, and then it's gone through audit and risk committee as well. So I think we're pretty happy with it. I mean, I think we are all pleased that we are spending the money. I think the promotion point is an interesting one. We've accessed some of the national NHS charity money now by signing up to that, which obviously is positive, and that's benefited the fund. But I think we should have a think about how we could publicise it further.
Stephen Dilworth?
Nothing to add to that, Andy. Yes, I think we're now spending more than we have done, certainly in my memory. So I think that's good. And staff are increasingly aware of the facility. Not totally aware. I think you still find pockets where you don't appreciate it's there. But it's being used. And at that rate, we've got about 3-4 years left. So that's good.
Okay, thank you very much, Stephen. Azra, I certainly would like to see us publicise it more internally, and if there is an opportunity for us to get some more money in, great. But we've got to have as I say, a purpose. What we're going to do with it, giving people ideas about what they can spend the money on, I think will be really helpful. Other than that, you're asking us to approve, are you not?
I am.
Do we approve, colleagues? We do. That's unanimous. Thank you for that. Before we have a break, Sue has asked about the health visiting service and whether or not the comments made by Joe are raised prior to handing over the service totally. Would Oxleas be able to do this? I take it that's our concerns about safeguarding, is it not? Was that your point, Joe?
I think there is a point about safeguarding, which I think there is some current concern about, and I think more specifically with some of the lessons that we've learned from the mortality committee regarding some of the sort of the deep dives we've done. So, for example, co-sleeping, people sleeping on sofas and things like that for the deaths of infants as well.
Thanks. Ian, please.
I mean, our staff are transferring, so they will take that knowledge with them.
Thank you. Ian.
Yeah, thanks, Andy. I mean, just a couple of things just to add to what Joe's already said. I think because of recent circumstances, there's quite a lot of system focus on child deaths within Greenwich. So I think there are quite a lot of forums which are bringing different bits of the system together to focus in on this. So I think that there is a degree of oversight from a commissioning perspective as well, which will obviously continue when we're no longer the provider. And then the other thing is that I'm very happy to link in with Lisa, who, as part of the handover process, is obviously linking with a new provider, but also commissioners as well. So there's a couple of ways of getting those messages across. And as Joe says, staff will be transferring, and I think that's significant as well.
Yeah, thanks very much for that. And a separate issue, Ray has raised the point about the COG agenda, the Council of Governors agenda, around the suggestions for generating income. Perhaps we just have an item on charitable funds, and to say how we might generate income, and also about what things these might be spent on, and perhaps something also on the NHS charitable funds. Matthew, please.
Yeah, thanks, Andy. I really welcome that, actually. I'd like us also to think about how we can generate a bit more income, because we're starting to build up a bit of a head steam around this. And, you want to have a certain amount of reserves. Is it 9 months Charity Commission recommends in terms of reserves? I can't remember. Nina would know, wouldn't she? But, certainly when I was at the MS Society, there was always this issue about running your reserves down to the right levels. But, to think about where we can spend it, there's a real opportunity to invest it in staff well-being and in patient wellbeing as well, and thinking about some of the areas we can create. And I think actually the voluntary and community sector partnership hopefully will offer us some different ways to think perhaps about how we leverage the amount of money we spend and the size of the employer we are in the local community as well. We've been doing some really good work with London South East colleges around routes into employment too. So I think there's something about thinking about the Oxleas charity not just as a small pot of money, but as a way for us to behave slightly differently in terms of our social responsibility. And remember, before COVID, we were talking about anchor institutions a lot. And I think, there's been, other things to think about for a short period of time, but we do need to re-engage with that. And I think to think both about charitable funds, their expenditure, income, and our broader sense of corporate social responsibility, it'd be a great thing for the governors to help us with.
Yeah, well done. Well said, Matthew. Thank you very much indeed. Right, we'll have a break. We'll reform at 12:10, please. Thank you. So welcome back. We will now move on to item 11, Performance and Quality Assurance Committee. Yemisi, please.
Thank you, Andy. So the report is in the pack, and I'm assuming everybody has read it, so I'm only going to go through certain highlights. First of all, I think it's true to say that we continue to have a very robust and rich ongoing discussions about our bed usage and talking through the challenges that we're currently facing, where that we have yet to still have defined KPIs, but in terms of discussing the movement of travel or the actions that we're currently taking, we are being given a certain level of assurance around that, and it takes up quite a significant proportion of our discussions during our committee meetings, but it's really good to see that going. I also wanted to highlight partnership working with the district nursing team, and this was really positive to see, considering the amount of concern we've had about the workload of the district nurses in the past, and it's also on our risk register. So currently, the continuing healthcare nurses who are employed by the CCG have been redeployed to support our district nurses in Bexley and to help in Meadowview. And they're also helping with some of our home-based vaccinations. So that's been really positive. Moving on, in terms of SNET, we were given that data, which was really, really good, and we've exceeded the targets there. And the committee then went on to ask questions about the qualitative data, just to be able to see what the outcomes of using SNET are. So there will be an audit done from a qualitative data point of view, and the patient experience team will be taking a lead on that. As always in PQAC, we discuss restraints, and what was good was the developing way that data has been presented to us about restraints, about the types of restraints. And in our January meeting, we asked for more, like a desktop review as to what the data was telling us, and that's been incredibly useful, especially around our prone restraints that we are working to reduce to zero, as we've discussed in our formal board meetings in the past. And the data that we received of the desktop review and that we went through in February was really interesting as to actually the dynamics of how restraints happen and how it affects the patient as well as the staff member. So there were also discussions around ethnicity data of staff who are involved in those restraints. And I think the last thing I wanted to mention was, as we've seen, our risk register presentation has changed, and Sue was there and able to talk to us about our long-term risks and whether they should be tolerated or not. And as a committee, we decided that actually, in terms of long-term risk, it would be useful for her to go and sit with the committees that sit below PQAC and to have discussions with them about what we do with those risks. And we also considered whether we needed a risk around staff who were hesitant about taking the vaccines. So we will continue discussions with that, I believe, at our next meeting. So that's all I was going to say from PQAC, but happy to take any questions.
I'm just finding the question that Ray raised on restraint. Sally, can you remind me, please?
It was about the ethnicity of people involved and staff involved in that. So Yemisi did mention that. I don't know if there's any more to add on I suppose what we're doing with that information and how we're taking that forward.
Was there also something about the date that we've got when we think we're going to achieve?
It's with the on the risk register, whether how optimistic are we about achieving reducing that risk within the time frame, or is that over optimistic?
I think, yeah, if you wanted me to answer that. So yes, in terms of the ethnicity data for restraints, that data is due to come back to us. And in terms of the achieving 0% prone restraints, I believe we are working on analysing the prone restraints that we've got at the moment and resolving those kind of issues. So it is actively being managed within directorates as to how they can drive down their numbers and also drive down the durations. In terms of whether we can hit 0% by, is the date the end of March, or it's the 6 monthly?
September.
September, right. I believe other exec colleagues may want to comment as to whether we can reach absolute zero or we can get incredibly close to it. Because I feel the way that we are going, the direction we are going with the focus on it and the fact that we are getting such rich desktop reviews, we are heading towards that goal.
Thank you. Jane, please.
Thank you. If I could just go back one step, I think Ray's question was whether we collect ethnicity data on staff involved in restraints. And the answer is on Datex, the staff's details are added, so that can be tracked, but there's usually a number of staff involved. So it would be very complicated to run a report to look at the ethnicity of staff involved in restraint, but we do know the demographic profile of our teams, so we could probably just look at the different teams that are involved in the highest number of restraints if necessary, rather than looking at specific individual cases, which may be very difficult to analyse and might not tell us anything. In terms of the progress around restraint, the restrictive practice group is making good progress. However, I think the message back, particularly from ward managers, is that whilst we're striving restraints, we do have to remember that it may not always be possible not to do a prone restraint if it's clinically indicated as the best option. But what we are working towards is really trying to take those lessons that we're learning from prone restraints and restraints in general and put some of the quality improvements in place to make sure that we're doing this as little as possible. I can give you the assurances that all wards are working really hard on this, all ward managers and matrons, and they're very, very engaged within the Reducing Restrictive Practice group, which is chaired by Christine Capopo and is held regularly now.
Thanks very much, Jane. Very, very helpful. Any further questions on PQAC? If not, thanks ever so much for all the work that's gone into that, and we'll move on now to quality improvement and Amlan, please.
Hi, thank you, Chair. A few bits I wanted to pick out of the report. So one of the big themes coming through from the discussions is about service user involvement in QI projects, and one of the outcomes that everyone involved in the committee is keen to see is some kind of infrastructure whereby service users are involved from the very outset of the beginning of the project. And I'm pleased to say that Neil Springham, with IFE's support, have agreed to take the lead on bringing this back to the committee for the next committee's discussion. So I'm really looking forward to that. There's a lot of enthusiasm to make sure that we do that from the very outset. There were a couple of really interesting projects that we heard about in some detail. The first around the perinatal service, particularly around improving the triage process and communicating the outcomes with those, particularly those who haven't been accepted for the service, actually, which I think is really important. Often the tone and content of those letters that go back to potential service users of that service just don't quite hit the right tone, and involving patients with how that letter should be phrased, how helpful it can be, was actually just seemed to me like a really good tangible outcome of the project. So that was a really well done project. Similarly well done project was around the physical health of those patients seen in forensic outreach services. This is often a population that is very, very difficult to reach and engage, but we know that they have worse physical health outcomes than the general population. And there's significant work being done by the forensic outreach teams to use those existing clinics where we know there is good levels of engagement to also further investigate and manage physical health problems at the same time. So a really good initiative, and actually a very interesting debate that followed about whether we're actually doing things that should be done by primary care. And there is an interesting debate about whether the more we do things that should be done by primary care, does that mean that actually we are creating a rod for our own backs? I think the reality is that these are individuals that rarely go to the GP, and their physical health does need to be addressed. So we took the view that actually a twinned approach of making sure we were doing the best we could, but also engaging GPs at the same time in terms of taking some of this work on, was the best way forward. Lastly, there was an update from Greenwich directorates on their QI progress, a few problems highlighted and a few problems for them to solve. I think one of the things that really did come through that discussion was how we might get better at sharing some of the good work between directorates. And again, a few clinical directors have agreed to take that on as a project in itself, to come back to the next committee to think through how we share those lessons more effectively. But those were the highlights I wanted to pick out. Happy to take any questions.
Thanks very much, Amlan. Any questions for QI? If not, thanks very much indeed, and we'll move on to Business Committee, and Jo, please.
Thanks. So if you take the cover sheet, the first bullet, I'm going to come back to Azra on that shortly. There's been some moving around in some of the numbers, but just to highlight a couple of other areas, you can see our COVID-related cost went up in the month. Not surprising given the peaking in the pandemic, although there was a little bit of catch up there from health roster, and we're obviously keen to make sure that if there is any further catch up to do, we get on top of it this side of the year end. High external beds in January. I think that's probably come down a bit since then. If you go on to the second page of the cover sheet, it's good to see that the provider collaboratives and the complex care budget, activities that we are undertaking with the SLP, are broadly coming in line with budget, with a little bit of potential there to improve upon a sort of break-even position. And then if we move further down, we had a quick look at the final Gatwick bid. We approved that at a board last month, and there were some fairly minor changes to the financials, which Azra talked us through, that didn't raise any concern. We'll come to the external bed contract in part 2. And the final point I want to pick up is on the risk register. It's fair to say that at the moment we are waiting to hear about what the financial regime will be for 21-22, and it is likely, once we are clear on that, and we know that it's going to involve the ICS more substantively than it's done in the past, but once we have a clearer view on that, we will update our risks around financial sustainability, CREs and things like that, to reflect that. Azra, do you want to come back to the first bullet, including picking up Ray's point about retained services? Thank you.
Yeah. So if I just start with the retained services and exactly what the issue was that we've been discussing actually at the Business Committee over a number of months now. So this appeared effectively in November, was when the issue first raised. So we get a whole range of monies through NHSE. It's principally around our specialised services. So at the same time as they put through the provider collaborative adjustment, for which we were fully funded for our lead provider collaborative role, they adjusted the retained services, so everything else that we had received through NHSE at the same time. And the problem has been that that balance for all of the retained services, and that includes things like the Oxleas prison service, elements of pharmacy, but a range of other specialist services, they made an adjustment to that we couldn't reconcile at the time, and that in reality we felt was £4.2 million less than what we had put it into the month 7 to 12 forecast that we were required to put forward in order to nail all of those financials for the second half of the year. We've been in ongoing discussions with NHSE in regards to that, and we had been in previous months prior to month 10 effectively accruing the difference because there was recognition at both ICS and London region level that we definitely hadn't got the correct amount of funding flowing through that area, and it was expected that we would resolve that issue with NHSE over the course of the next couple of months. As at month 10, what we were requested to do was to take out that accrual so that when the figures were consolidated on a national basis, we would be able to highlight that issue, because the figure is about £24 million in London if we were to look at it in totality across all of the areas, and it seems to have impacted principally on those areas that became that were impacted by the provider collaborative. So what they've effectively done is they've taken away too much of the retained service elements, although there were a number of providers that actually received more money. So we've continued with this ongoing reconciliation. The figure was put through for month 10, and there was an agreement that we would find a solution at month 11, either at ICS or London level, even if we didn't resolve it with NHSE. And we've been progressing the discussions at ICS level. So for month 11, we're expecting this to be resolved, but it will be via an ICS solution rather than an NHSE solution, because that is taking longer than we anticipated to resolve. The key issue on that is what will happen for next year, because that resolves the issue for 2020-21. But given the nature of the planning, there is expected to be rollover budgets for Q1. Now, we still don't quite understand what the planning guidance is going to be for the Q1 rollover. We're expecting that guidance to come out sometime in March. It still hasn't come out now. We're expecting it round about mid-March. And then we will have to do a piece of work within the ICS to actually understand what that Q1 figure is going to look like. They've been very clear that we will be given an ICS control total, and we will be expected to live within that control total amount. So that's going to really be a determinant that we will probably pick up at the April Business Committee, because I don't think the guidance will be out. There may be early guidance out for the Business Committee, but we won't have worked through all of the mechanics of that. I think the other element just to pick up in regards to planning, because it's not specifically covered in here, is there will be a requirement for a separate mental health planning exercise for 21-22. We're expecting the guidance for that to come out sometime this week, and that's expecting to be a 4-week turnaround. That's very new information because it wasn't actually discussed at the Business Committee. So we'll be doing that planning round over and top of a more generic planning round for all the rest of our services, inclusive of mental health. I hope that answers your question, Ray. It was rather a long answer. Great. The other question that was raised in regards to the papers was the fact that we'd not ticked or commented on the equality aspects of finance. And I think that's in reality because a lot of the equality decision is made at the point that we actually make a decision on finances. And these reports are historic. They're kind of a marker of the financial consequence of decisions that we have taken. So when we actually make those decisions, for example, when we have a business case, we do a full EQI assessment at that point. that would take into account what's going to be the overarching impact on workforce quality, finance and equality. The other area that we look at that, and we'll be stepping that up as we move into 21-22, is an EQIA assessment on all of our SIPs to make sure that when we make savings plans that we fully understand the impact on both equality, finance, operational impact and on quality. And lastly, there was a comment that we'd said it came out of the strategy paper about the SIPs figure, if I just address that now as well. So we entered 2021 with a £13.5 million SIP requirement. In reality, that has been developed because as the NHS started to give pay awards, and it really impacted from about 2017-18, because prior to that, there had been, because of the austerity, there had been very little pay award adjustments. The way that we're funded in mental health and community health services, because we've got blocks, we only get the net uplift every year in terms of inflation. So what they do is they do a gross inflation uplift that completely covers the pay awards, non-pay, a whole range of other costs, and then they have an efficiency target. Now that works well for acute trusts because they also get an uplift to the prices they get paid for their services. That does not happen for mental health and community services. We simply get the net impact of that uplift. And that net impact has effectively resulted in both mental health and community trusts having to make savings greater than what the national efficiency target has been in any given year. And what's happened is over the last 3 or 4 years, we have struggled as a trust to make those additional savings. And to put that into context, those savings nationally, the national requirement, has been between 1 and 1.3% over that period of time. We as a trust have had to make 2, 3, and then up to 5% efficiency savings in order to be able to pick up all of those costs. The reason that we haven't actually gone into deficit as a trust during that period of time is we've used a combination of, we've sold assets, and that has allowed us to basically receive both cash and an income adjustment on the gain and sale of those assets. And B, we have used the strength of our balance sheet to support operational in-year delivery. That can continue for a couple of years, but once you get to the end of about 3 years, we would have nothing left in our balance sheet to be able to support those costs. So it is incredibly important that we, as we begin to put in recurrent pay and recurrent non-pay increases year on year, that we're able to balance those off with efficiency savings that are cash releasing, that are able to offset those. Otherwise, we effectively hit a cliff edge in about 3 years' time. That was quite a long-winded answer, but I'm afraid it's quite complex in regards to the finances. I did have a little slide, but I'm slightly wary of trying to share that because we went through this round about February time, just before the pandemic. I can try and share that if that would be easier, but Matthew, I think, wants to come in, so he can maybe take a view on that.
Yeah, Matthew.
Yeah, I mean, I'll let Andy decide if we want to go into this slide. It might be that we need a separate discussion at some point around this, but I think there's also the point to bear in mind that we've had some useful benchmarking done, particularly looking at our mental health services so far, but we need to do the same for community. And we can see that for all 3 of the boroughs where we're funded to provide mental health care, we're in the bottom 25% in England. We are significantly underfunded compared to the median. And it's notable when you look at the other systems in London, there's only 1 or 2 in London who are funded above the median, but they do have clearly access to considerably larger resources than we do. Slam are likewise in the same position. I think South East London as a whole doesn't have a single borough that's not in the bottom 25% in funding. And as a result, there is we need a live conversation with the ICS around here, and we have started this in earnest, about the extent to which we're able to balance this fact that for years now, our basic staff costs have increased faster than the rate of the increase in our income. that hasn't taken into account necessarily the growth that we're encountering either. And we are certainly in mental health terms significantly underfunded compared to the English median as well. And I think when you look at all these things in the round, and yet you look at the fact that we've actually got on a number of indicators, whether it's length of stay or others, you know, we've got some extremely good levels of performance compared to a number of our peers. I think we manage a very tight position well as a trust and have been doing for many, many years. But as Azra says, that you run out of road when you continually go to your savings effectively to pay your income and expenditure. Then there comes an end point, and that's where, you know, some of the conversations we had earlier about the bed base versus mental health assessment suites, etc., some of the pressure on community physical health teams as well. You know, this is that pushes boards like us into a decision point around whether you prioritise retaining a balanced budget or whether you look to the pressures that your services are under. Because I think it's something around 40 million quid of savings has been taken out of Oxleas' position on an I&E basis over that 4 or 5 years that Azra's talking about. And you know, you run out of road eventually with that. And we're the only trust in South East London that's still managing a balanced budget. We are doing very well on that front. But you know, if we say that we want to balance our budget and prioritise improvements in quality and safety and capacity, you know, those things are not all consistent with one another without more resource. And the budget looks as though the NHS is in for a hard couple of years here as well. So it's a tough environment, and one that we as a unitary board need to be very cognizant of when we're making decisions about what really matters.
That's very helpful, Matthew. Azra, I thought it was a really good summary, actually. Really well done. Thank you. Just coming back to the 2.8 accrual and this now being sort of pushed back to the ICS. How is the ICS going to sort this out? I mean, if we think we're down, you know, some money, and are we going to get some money from someone else within the ICS when this seems to be an NHSE problem? What issue?
So if you remember, when I was talking about that summary, I said there was some organisations that received more than they were anticipating. So we happen to be in the fortunate position of being in an ICS where that is the position, and it will allow it to cover off the majority of the £4.2 million issue that we've got this year. So
we're expecting to get some money off the others then?
There'll be a rebalancing across the patch, Andy, where and it's a classic NHSE black box situation where we can't quite figure out what's happened. But when you look at the net position, roughly the right amount of money was given out, but it doesn't appear to have been given to all the right people. And so some people ended up with a surprising bonus, while others were slightly behind where they should be. And when you look at that and balance it off, it all adds up quite nicely. It's the same across all the other ICSs. Some of our neighbouring trusts, I think one of the North London mental health trusts has had to post a £10 million deficit for month 10. But that will be corrected by month 11 because they've rebalanced it.
Right, so we're confidently hoping this is going to be rebalanced.
I've got written confirmation of the fact that this will be fixed for month 11.
Well done.
For both the ICS and the other organisation.
Okay, thank you, Azra. That was really good, very helpful, and a very clear explanation of all of the issues. So well done. Is there anything else for Azra on that, or anything else on business committee? If not, we'll go on to partnership, please, Jo.
Thank you. Again, just to highlight a couple of things in the paper. So you can see we're expecting to see and sign up to a new Section 75 partnership agreement with Bexley Care. We were thinking that had to get done by the end of March. We've had a little bit of a time reprieve, and you can see that it's due to come via partnership to the board next time we formally meet on the 6th of May. Home First, a number of us saw a presentation on Home First. We discussed that further at the partnership committee and agreed that NEDs would be invited to a more detailed session so we can really get under the skin of the proposal and understand the impacts, I guess, at a team level. And we then also talked about, whilst I think everyone was broadly in support of the proposal across the system, it was important that as we got more detail on this, appropriate proposals in terms of the effect on Oxleas were brought to the right governance committees. And then the third thing to mention, and we've already touched upon it, is we continue our meetings with Lewisham and Greenwich Trust. We had one earlier this week. perhaps despite some of the weights we talked about earlier, I think it's fair to say that relationship has significantly improved. There's more to do, but there's also some other areas that we are exploring with Lewisham and Greenwich as well, which I think is positive. And as well as our collaboration with the SLP, I think we're keen to ensure that we also collaborate with LGT on things that make sense for both trusts, given that we have such a strong geographical relationship with them, and our service users use both trust services. That's all I was going to highlight, but happy to pick up any points.
Anything for Joe on partnership? If not, I think it seems to be proceeding very well, Joe. I think there's as you rightly say, I think relationships with LGT have certainly improved, and big thanks to the exec and clinicians for working on that relationship. If there's nothing else on that, we'll move on to infrastructure, please, Suzanne.
Thank you, Chair. The governors have raised a couple of issues in advance, and I'll come to those in the context of my comments. And thank you for raising those issues. I'm going to take the paper as read, but I just wanted to make a few comments. The first point is that the last infrastructure committee meeting was one that we reduced in length in accordance with wanting to streamline governance during the pandemic. So it was a slightly abbreviated meeting that nevertheless managed to cover all of the issues that we'd have expected to cover according to our yearly action plan. We also introduced a new agenda item, which I think was an important one, where we recorded some of the notable progress or notable achievements in the infrastructure realm since we'd last met. And I've introduced that because I think it's a way of ensuring that as a committee, as well as thinking about assurance, we're also noting the excellent work that is occurring in areas over the trust. So in terms of the finance report, we noted that there has been some slippage in our expenditure during the year. One of these is on anti-ligature works, and that's been held up by the difficulties of negotiating and navigating the PFI. I'm going to come back to ligatures a little bit later in my comments. The same applies to Green Parks House, and one of the things that has held up work on A block at Queen Mary's is that it's currently or has been used as a vaccination centre. And Rachel may want to comment on these issues a little bit later if anybody has further questions. We received a number of updates. These included sort of an update on Estates IT and the new ways of working projects. We also asked for a specific update on the ongoing ligature works, and I just wanted to respond here to some of the questions which have been raised about this. I think it's probably important to point out that one of the areas of increased understanding, I think, on our ligature work over the last few months has been to recognise that there are three elements to this, all of which need to be addressed in a sort of integrated way. One is around environmental management, to ensure that as far as possible we reduce ligature risk in the environment. The second is to ensure that where there are residual risks, because there will always be some residual risks unless we wrap people up in ligature-free suits and put them in a cell and remove their shoelaces as a matter of routine, that we need to have mitigation plans in place for managing the residual risks that remain. And there's a third element then to ensuring that all of that, particularly on the clinical management side, that practice is embedded in an ongoing way in the way in which patients are managed on the wards once those risks have been identified and the necessary risk mitigation is discussed. So just to sort of comment on how that has been proceeding, there has been joint work between the estates and a clinical specialist using a new iPad-enabled approach, which means that in the process of doing the new audits, reports can be immediately delivered rather than having an inbuilt delay on those reports being delivered. And I think that the joint working between estates and the clinical specialist, along with the ward managers, has actually been extremely successful. We did note that this is one area where we've made very significant progress, and I think that one of the questions is whether or not we expected that we would have dealt with our ligature risks in the time frame that we've set. I'm confident that we are going to, and not only that, but I'm absolutely certain that we must. This is an issue of, critical issue of safety, and one that we have to achieve in the timetable that we've set for ourselves. Just one last point on the sort of PFI challenge. I came to chairing the committee a little over a year ago, and it's a source of immense frustration that one hears that we can't get work done because of the difficulty of working with the PFI, which also has to be routed through our partners at LGT. We did have a discussion about this at the committee and noted that there had been an extended discussion between Stephen Dilworth and Rachel Evans some time ago to try and bottom out whether there was anything more or different that we could do. And I think the conclusion that they came to is this is a perennial problem that we simply have to go on managing as actively as we can. So the last comment I wanted to make, and I value the point being made that there was nothing on our report about the implications, particularly in relation to quality, equality and service user. And I think that point was well made, and it gave me pause to think what really ought to go into this section. Interestingly, I think we do have quite a lot of discussion about this at the committee, so that issues around digital inclusion, for example, are a constant part of our discussion in relation to new ways of working and to building on some of the digital gains that we've made in the pandemic. And I think we are conscious of the need to ensure that as we roll out new ways of remote working, that this doesn't exclude some of our service users. We also have discussion, as we did at the last committee, for instance, about vulnerability to infection and needing to ensure that we don't treat all of our service users as equally vulnerable or invulnerable. But I think that going forward on this, what needs to be included in future in that part of the report is just a comment probably on how we've taken this into consideration in our discussions as a committee.
Thank you, Suzanne. Very good report, and thank you for all the effort that's gone in so far on those very critical safety issues. Are there any questions for Suzanne at all on infrastructure? If not, thanks very much indeed for everything, Suzanne. Thank you to Rachel T. Evans as well for all of the work that you've been doing on this one. Let's move on, please, to workforce, please. Nina, I haven't got Nina, so Rachel, please.
Hi, Andy. In Nina's absence, I think I'll just treat the paper as read, if that's all right. I would just highlight one addition from how we've operated previously, which is that we're now inviting our directorate workforce committees on a rolling basis to come and present at the Workforce Committee, and the Greenwich Workforce Committee presented at the January meeting, and I think we found it really useful to have that level of granularity in terms of what's happening on the ground. We're going to be alternating a directorate focus 1 month with a focus on a particular network at the subsequent meeting. So hopefully it will just give us a little bit more opportunity to hear directly from staff and their concerns. But that was what I was going to raise. I don't know if Joe or Yemisi wanted to come in with anything additional.
Nothing from me, I think. I agreed. It's really good to have the directorates presenting. You get sort of underneath the covers a bit in some of the issues.
Stephen.
Yeah, thanks, Andy, and thanks, Rachel. I just want to raise the point about lone working, which is touched on in these minutes, and it's also a question that Yemisi raised on page 243 of the bundle from the minutes, because it's certainly, I think, an area which gives us all underlying concern, even though we've taken lots of mitigations. So at the Workforce Committee, I understand the explanation of why we can't hit 100% of usage of either Sky Card, or I think it's called PeopleSafe now. and we can't get to 100% because of absenteeism, staff holidays, etc. But anecdotally, I get the feeling that also not everyone is using these devices anyway. And I'm just concerned that we make sure that we don't take our foot off the accelerator on this one, because it's certainly, from a health and safety point of view, all we need is one incident to happen one day, and you know, someone will get injured or worse, and obviously we have a big responsibility there. So I guess it's partly an observation, but what reassurance can you give us that even though we're not going to hit 100%, we are doing everything we can to make sure that everyone who we think should have a device is actually using it?
Ian, did you want to come in on that point?
Yeah, if that's okay. So, so we have data around which teams are using these devices, because obviously not all teams have adopted Sidecar or People Safe. So the health and safety team, they generate a monthly reports for each team, and then also a report has all the members of staff within that team and their usage for that month, and that is shared with service directors. It is an item as part of the health and safety component of each DMT. They look at it, then obviously they work with team managers to follow up why device is used. And to close the loop, that is being discussed at the service directors meeting every month. Is there a problem with action?
I think I had trouble hearing that, Ian, so it may be, I don't know if anyone else did, maybe just the reception's not so good, but maybe we can just exchange thoughts outside the meeting. I don't know if it was just at mine.
Could I help?
Do.
It's Rachel here. What Ian was saying, I think, is that the data is sent out on a monthly basis to every team. So every team has the information to see how they are performing. They also have the ability to go into the system and look at how individuals are using their devices and following it up with them. They also have it on the agenda for every directorate management meeting that takes place within the directorate, and Julian regularly attends the service directors meeting to give them an update and to talk to them about any issues and support any further work that they might need. So there's quite a robust process in place, and it's a difficult period, I think, as well at the moment, because of course many people are working from home. So there are probably people who've got devices who aren't using them in the same way. So once things, I think, get back to whatever our new normal looks like, then we need to be absolutely ensuring that those who should be using them are using them.
Thanks very much for that, Rachel. Yemisi, please.
Thanks, Andy. I just wanted to acknowledge from the workforce committee point of view how much I really appreciate the constant contact with our exec members. Even though we only meet up formally as a committee every other month, there has been opportunity for us to discuss things in a just-in-time basis and to, you know, thrash out issues. So I feel really connected with the issues that are occurring, and I really feel that, you know, our views and our opinions have been taken into account. So it's positive to see that change. So, you know, thank you so much, Rachel.
Oh, well, thanks very much indeed. So is there anything else at all on workforce? I think the only one thing I was thinking about was the disproportionality on discipline. I know we've made some progress on that. But Rachel, I don't want us to surprise you with this, but any update on that?
I feel bad now, Andy. I'm afraid I was just responding to say thank you to Yemisi. Could you repeat the question? My apologies.
Yeah, it was really around the disproportionality of discipline against our BAME staff.
Yeah.
And I know that's has improved. I just wondered any further update on that at all.
So it's something that we continue to focus on really clearly, and Ray and I have discussed this separately outside of the meeting. It's we are making real strides, but we are not where we want to be. So we have much further to go. And if you look at the detailed letter that we sent back to the CQC and in response to a range of issues which relates to the experience of our Black, Asian and minority ethnic staff in Oxleas, you will see that that's an area where we continue to devote real efforts to try to drive down and to reduce that disproportionate likelihood of BME staff going into disciplinaries. The just culture approach is proving to be really helpful. The thing that's difficult to get under the skin of is the fact that certain of our teams are much more likely to lead to disciplinaries happening. So we know that there are real hotspots for disciplinaries, and in those teams there are far higher numbers of BAME staff. So it's quite difficult to unpick what needs to happen in order to make sure that we reduce that. But we meet every few months with Juliana Frederick James, the chair of our BAME network, and with the deputy too. We go through the data in some considerable detail, and we feed that back, and we continue to improve our just culture methodology. I genuinely don't think there is any more we can be doing at the moment, and we are not sitting on our laurels, but it's still something we're going to continue working on.
Thanks very much for that. Thank you, Rachel. So we move on now to audit and risk, please.
Thanks, Andy. Yes, mostly the cover sheet, I think, is very self-explanatory. As part of our normal rota, we have business committee attending for the January meeting, and as we've just heard from Azra and Joe speaking, very much the main risks are around those unknown financial controls going forward into 21-22. And we've got infrastructure coming for our next meeting. And as we'll all be aware, but just to remind everyone, over the course of 12 months, all the subcommittees attend audit and risk. And I think it is a very useful system that we've got there for exploring existing risks and risks that are just on the horizon. Then two other points, both to note from the internal audit and the external audit. We had two reviews from KPMG. The first one was on the core financial systems, which I'm pleased to say received a significant assurance. This is in respect of patient monies, and I must admit I had forgotten just how much we hold there, but KPMG reminded us that over the past 12 months that's varied from £247,000 to £263,000, so it's quite a chunk of money. But congratulations to Ezra and the finance team. It's not often you get significant assurance, but that is what we got on this occasion, so that was very pleasing. The other report was in respect of clinical audit. There were 5 recommendations, 1 high and 4 medium ones. The only thing I want to draw your attention to on the high one, the work will not be completed till September 21. There are reasons for this, due to staff being taken to do other projects during COVID, and also new staff being recruited as of March, so they need some time to settle in. In the meantime, work is already ongoing on the high level recommendation, or high priority, I should say, recommendation. So it's not as if nothing happens till September 21. And we've also asked for an interim report, which we should probably get at the May meeting. So the committee in the round in discussion with KPMG agreed that it was okay to have that end date. The other 2 points from the external auditors. First of all, there is a slight adjustment to their fees, but we've known about this for a while. This is as a result of more detailed audits, standard across the sector, and also much more work being undertaken on value for money, which I'll come to in a second. I have mentioned this at the Council of Governors meetings as well, and both Ezra and myself and the Audit and Risk Committee feel that this increase is justified, but we'll take that through to Council of Governors. Value for money, just to flag really that this is and we said this, I think we said exactly the same last year, this is an ever expanding area. It's particularly one that Steve James has commented on several times about how rapidly it is expanding. I mean, basically it's about economy, efficiency and effectiveness. but those three areas and the requirements for NHS value for money audits and what the external auditors need to look at really is greatly expanding. And there's an additional problem that we don't always have the rules and requirements as early as we should do. That's not an Oxleas problem, that's a whole sector problem. So it's a tough area. They'll be looking, Grant Thornton will be looking at informed decision making and sustainable resource development. So all this will be coming into their research and analysis and audit for this year. So I'm only mentioning it to you that it's a phrase you'll be hearing increasingly over time, value for money. That's it from me.
Thank you, Steve. Any questions for Stephen on audit? If not, thanks very much. And thank you, Stephen, and thank you, Azza, for all the work that goes into audit and risk. If we go on to the board visit reports, they are beginning to be put back in place now. I should look forward to some more reports as we go forward from here. If we look at what we've got in the file in the papers at the moment, we've got Steve James, please.
Yeah, it was a very interesting visit. I think that to go back to one of the conversations we had a minute ago about lone working, we had a discussion about that, but they hadn't taken up Skyguard or whatever it's called now. So we do need to do some work on that. One thing that really struck me, which really ought not to have struck me, but did, was, of course, these guys in the team had gone and visited people who were very vulnerable on a face-to-face basis throughout the whole of COVID, which I know it shouldn't have passed me by, but sort of had. So I think we should acknowledge the quality of the work to continue to go visit people and see them face-to-face throughout the whole COVID pandemic. And I just think we should acknowledge that, because a lot of things went remote or we stopped doing things, but not in this team. The issue about high caseloads was emphasised, and a number of things around cars, which I won't go into any details now. But it was the thing that really struck me was the majority of their visits were still face-to-face throughout the whole thing, and we should just acknowledge that.
Yeah, that's a very good point, Stephen. All of those people have just carried on throughout, haven't they, throughout the pandemic, and without any complaints about Teams meetings, because they've been out there doing it in the front line. Stephen Dilworth, please.
It's not a question for Steve, Andy, but if we finish with one, I'll go on to my report.
I'll just come back in a second. I'll just go to Matthew and then I'll come back to you, Stephen, if that's all right. Thank you.
I was just to echo what Steve James has said about some of the teams. I mean, I know from talking, I spent a bit of time talking to the Bexley team a while ago about this, and I think what they did was, for quite a lot of the people that we provide care for, some of the remote consultation methods just aren't appropriate. They just don't work, and they don't fulfill the same sort of function of assurance for us around the safety of someone's living environment that you do from getting to see them. And I know lots of the visits happened at sort of with people stood outside doors, talking through doors, etc., because they had to for safety's sake. But I know some of the teams have really gone above and beyond for that. And it's not just our teams. I mean, Andy and I think, met some of our volunteers at Queen Mary's, and talking to some of the volunteers who acted as drivers for medication for children with complex needs, these kinds of things. It was really interesting hearing how our staff have been a real lifeline for some vulnerable and isolated people right throughout this pandemic, and how seriously they've taken that responsibility. And I do think it's been kind of quietly there under the radar. We have had a real focus on how much stuff have we moved to remote and how much digital we've used. I suppose the corollary of that is we haven't had the same sort of focus as how much stuff did we continue doing face to face, because that's how we've always done it. But actually in the context of, particularly if you think about how scary it was last April and May, walking into someone's home to sit next to somebody in those kind of environments when the virus itself was still such an unknown. I think it did take a sort of quiet courage, really, and a quiet commitment to the work that is well worth us recognising. And I think we have said thank you to the staff a number of times, but it's really important for us to to bring these examples to the fore and not lose sight of them.
Yeah, thank you. Thanks very much. Well said, Matthew. Stephen, please.
Yeah, thanks, Andy. I just thought I'd report orally on a visit to Bettswold on the 17th of February. So we'll follow this up with a written report fairly soon. But certainly I know for Matthew, Ian and Lorraine, and you'll see it on page 254 of the bundle on the executive discussions. It's a ward that has given us some concern because of CQC interest, a higher level of complaints over the last 6-12 months, and also some resistance to body-worn cameras, which are again sort of built on those other couple of points as setting possible alarm bells. But in terms of good points, the meetings we had on the meeting we had on the 17th of February, there are some good things arising. There's a new head of nursing in Bromley, Catherine Seaburn, who's very much focused on the ward, plus a new acting ward manager. And I hope I get his pronunciation of his name right, Nadozi Amizi. And Lorraine was particularly commenting on how good his grasp of ligature works on the ward were, which is very good to hear. On the 17th of February, they during the course of our meeting, they travelled quite a journey from being resistant to body cameras to, by the end of the meeting, and Nadozi was saying what a good idea it was. So they have now bought into that and they are using it. There has been a technical problem, by the way, that the CCTV and the body cameras weren't always recording, but that is being dealt with internally. So it's one we'll still keep an eye on to make sure that improvement continues. But I thought just important to know that a visit was made and good news came out of it, really. That's all.
Thanks very much, Stephen. This was a really interesting visit. I did a visit. I do visits on my own anyway, so strictly speaking, not a board visit, but I did Oxleas House, all the wards, mental health liaison, HTT, etc. And what I was really impressed by was the enthusiasm and morale of people who've been working incredibly hard. It really did come across, and it was a really. They had some concerns, as they always do, but certainly on the wards, I was really impressed. I fed back some of the feedback from HTT around things such as parking, and Paul Carr's, interestingly, Steve, cropped up with them as well, and whether or not how they're supposed to operate if we're asking them to go backwards and forwards from hospital. So that's something hopefully that the exec will be picking up. Again, I was impressed with the ligature work. I thought it's really got through to ward level, which was really, really good. So, and again, we're talking about staff who've not been away from the ward, have they, from the very beginning? And it really was very, very impressive. So, thanks for that. Just on the visits themselves, Sally and I have been having some exchanges, and I've been talking to Neds about visits. Clearly, we've got to be guided by the exec, will be guided by the clinical guidance about safety or otherwise of visits, but it will be really good to start to see these visits in whatever form we're going to do to get back up to the sort of pace that we had before. Sally, please.
Yes, thank you, Chair. I just wanted to update the board on the actions being completed from the board visits. So just to assure you that we keep a database of all the actions raised through the visits, and then keep a tally of those being closed off. So over the course of our visits, we've had 350 actions raised. Currently, we have about 20 actions outstanding. Most of these kind of relate to more difficult to solve problems, such as parking. It's interesting that those have come up again in pool cars today. But just to reassure you that we do work with the relevant leads to make sure that the actions are taken forward and closed off. Thank you.
Thank you, Sally. We'll now move on to Council of Governors update. The paper is there. Sally, do you want to add anything to that?
No, I think that's complete unless anyone's got any queries for me.
What I'd like to say is I'm really pleased about the amount of energy and effort governors are putting into this at the moment. It is very impressive, and I'm very pleased to see new members in particular, and some older members, all really carrying out the function of the council of governors is supposed to do, which is holding the NEDs to account. So I'm grateful for just how much people have put into this so far. It's what a vibrant trust, foundation trust ought to be doing. So thank you for all of that. We now come on to any other business. Any other business from anybody at all? If not, thank you very much. Sorry.
Any other business? Just to remind the board members that the survey for board evaluation is open, and encourage people to complete that. And then we'll be bringing the findings of that to the strategy away day and having a discussion about next steps. And we can then report back to the next full board meeting. Thank you.
And Sally, just about the next meeting, can you just update us about for a moment?
So we have a part 2 meeting in the diary for the 8th of April, which is looking to sign off the procurement for Kent prisons, the bid for that. So it will be a commercially confidential meeting, but that's scheduled for then. And
then the next one in early May, yeah?
Then the full meeting in the first Thursday of May. Yeah.
Okay, lovely, thank you. Well, I'd just like to thank everyone. I thought it was a really, really good meeting. I'm very grateful for all the energy and effort that's gone into this. But a few particular thanks. I thought that Sky television item that Matthew referred to was really good, and I know there's a lot of prep went into that to get it done, and right up to the last minute you were being cancelled and then put back on again. But watching that on the television made you feel really proud. Actually, I thought that was really, really good. So well done on that front. And I think just the amount of energy and effort you exec put in, it comes across hugely. In very difficult times, you've been working long hours, under some real stress, and I know that. And sometimes I occasionally add to that stress. I do get that. But thank you very much indeed for everything that you do. I think we're coming to the end of this financial year, so we can almost sign it off to that extent and say thank you for everything you've done. I think and you've done really superbly well. So with that, we come to the end of this meeting. We'll reform for the part 2. Should we make that at let's be generous and make that 13:20? Would that be okay for the part 2? So thank you very much indeed, everyone. Thank you.